It's 12 here in Helsinki, Finland, and then I'm happy to say it's sun is shining, and then that don't necessarily happen every time. So now I'm in a happy place at the moment. And my name is Juha Kahila. I'm the chair of the Housing First Europe Hub Community of Practice for Housing First Managers Group, and also the head of the international affairs at the Y Foundation. And today, the Housing First Europe Hub is delighted to bring this webinar to you regarding older people and health issues. What are the benefits and challenges of Housing First programs? We have two excellent presentations coming up, and the idea is that first we hear both of those presentations, and then you are able to put your questions, ideas, thoughts, and comments into the Q&A box that you can find on the Zoom or in the chat box. Or after the presentations, you can also raise your hand and ask the questions. And today, it's a really honor to have these two great speakers to take part into this webinar. So we have Laurie O Donell, Research and Advocacy Officer at the Focus Island, and then she will present Growing Old at Home. And after Laurie, there will be Dr. Eileen Corroon Sweeney, General Adult and Old Age Psychiatrist at the Clinical Lead for the Inclusion Mental Health Team in Dublin South City, and she will present No Country for Old Men or Women, Health Outcomes in Older People's in Homeless Services. So off you go, Laurie. I think we are good to go, and feel free to start the presentation whenever you feel fit.
That's great. Thank you so much, Juha. So I'm just going to share my screen. There we go.
Perfect.
Is that perfect? Okay, so hi everyone. Thank you for asking me to present here. So today I want to tell you about the findings that we did from a study that we did last year to look at the long-term housing needs of our older tenants. But before I get into that, I just want to give you a bit of background about who Focus Island is and why we decided to carry out the study. So for those who might not know, Focus Island is a charity dedicated to ending homelessness in Ireland. Within that, we also have an independent property arm known as Focus Housing Association. This provides over 1,500 affordable homes to individuals and families across the country of Ireland, most of whom would have experienced homelessness or housing insecurity at some point in their life. So the reason that we decided to do this study was in response to concerns from our services about providing suitable support and housing for our mid to later life tenants. So the Focus Island research team conducted a telephone survey with our long-term housing tenants over the age of 45 to assess their housing need and investigate how we would provide suitable housing and supports for tenants as they age. So the reason that this age was chosen, not to offend anybody who is above 45, you're not old, the reason this was chosen was to incorporate the long-term perspective of the study, but also as well to reflect the evidence from our literature review that shows that those who've experienced homelessness are at risk of experiencing age-related health conditions much earlier than the general population. But I'll speak to that later on in more detail. So the aim of the study was to assess the long-term housing needs of our tenants and use the findings from the report as a starting point to help us develop a strategy for how best to help our older, how best to support our older tenants. So just very briefly to give you a sort of background in the methodology, we designed a survey following a scope and literature review that helped us identify which topics were most relevant for people aging in place and also older people who have experienced homelessness, which is kind of two different literatures. And so from that literature review, the topics that we identified as the most relevant were around housing, community, finance, support, and health. Our services then helped us identify 190 potential participants. Unfortunately, we didn't capture how many of those could have been housing first tenant, but that's a learning that we have, and going forward we will capture this if we do the study again. However, I do think that some of the findings in this report will still be applicable to housing first tenants, as there are similar characteristics with this cohort who would have at some point experienced homelessness or housing insecurity. So of the 190, 76 telephone surveys were completed between August and November 2022 by our peer research team. So that is a team of trained researchers who would have lived experiences of homelessness. So just to caveat that, you know, some of the limitations for this study, it is a small study. However, the findings do reflect and confirm a lot of the wider literature on the topics of aging and place. So just to give you an example, there we go. Just to give give you an idea of who it was we were talking about, just to give you an idea of who we were talking to, the main regions that the survey respondents were from were Dublin, Waterford and Kilkenny. Within that, our sample would cover a number of different types of housing tenants as well. So, but mainly people living in congregated and pepper potted housing. Some possibly would have been housing first, but unfortunately, as I said, we didn't capture that. But although we have a very small sample, they are from across the country, and it does cover a wide range of people with different needs and experiences. So I think it gives us a kind of better picture nationally of what our tenants' long-term housing needs would be as they age. Of those surveyed, 94% were under the age of 70, with those in their 50s being the largest age group that we spoke to. In terms of the main sources of income, disability allowance was the primary source of income for most participants. I think it was over half, followed next then by a pension. And finally, just to give you another idea, in terms of the social supports they received, almost all of our participants received fuel allowance, which for those who aren't in Ireland, is essentially it's a benefit to help you heat your home, so to pay for like electric and heating, which in Ireland during the winter is very much a necessity. They were also in receipt of some form of housing benefits package. So these 2 points will be kind of important once we get into the findings in a bit more detail in the future slide. But kind of the main finding that I kind of want to talk about today, which I think is really important because it will frame the rest of the findings, was our health demographics for our participants. So this showed that out of the 76 participants we spoke to, 64, so that's 84%, answered that they had one or more chronic health condition. I also just want to point out that 12% of our study said that they preferred not to say rather than saying that they did. So it could possibly be higher than that. So it could be a higher percentage, but we can't say. The most common health conditions among the participants were back pain, mobility issues, so things like getting up and down stairs, walking distances, etc. Psychological or emotional conditions. The primary ones for that were anxiety and depression, high blood pressure, and then lung or respiratory diseases. Again, the main ones for lung or respiratory were things like COPD and asthma. I think this is a really significant finding when you compare it against the general population of the same age group. So in Ireland, only 32.5% of men and 32.8% of women between the ages of 45 and 64 reported having a long-standing illness or health condition, which, when you compare to our study of 84%, is quite telling and really shows the impact of homelessness on our cohort. So moving on to the rest of the findings. So looking at housing satisfaction. So when asked, 82% of our participants stated that they liked living in the community that they were in, and 78% enjoyed living in their current home. When they were asked about the long term, whether they would consider moving if their house was no longer suitable, or whether they would stay where they are, 70% said they wanted to remain in their current house with appropriate changes made as they aged. Okay, so they just basically wanted to make it more accessible rather than moving at any point. The main issues that our tenants face to make the ones that did answer that the home was unsuitable, the main issues were around maintenance, lack of storage, insulation, and bathroom facilities. So by bathroom facilities, a lot of them were saying it's because they can't, access their shower. They needed a walk-in shower, which makes sense considering half of them had mobility issues. In terms of the area and community, so tenants found that when they were asked, the majority of our tenants said that services and supports were either easy or very easy for them to access from their current accommodation, which is quite reassuring. However, the areas that they viewed as difficult or very difficult, like some of the services they found difficult or very difficult to access, were health services, friends and family, local shops, and their GP or pharmacy. Now, 19% and 11% might not seem that big, but when you consider the fact that majority of the people we spoke to had chronic health conditions, it is a little bit concerning, and it's something that we need to consider, because that will probably only get worse as they age. In terms of living conditions and community, the things that scored highest were a safe neighbourhood, shops close by, cleanliness of the communal area, and accessibility to healthcare. Public transport options and green spaces were also viewed as important. They were 95% of our respondents considered them fairly or very important. So I think it's very telling that the majority of our people that we spoke to, accessibility and proximity are kind of the main things that they want when they consider aging in place. And I think that kind of makes sense when you consider their health conditions. So probably the most depressing statistics that I'll have from my findings, when we looked at finance and budgeting. So when asked about that, 62% of our participants said they never had enough to cover their weekly expenses, and 72% were unable to save some of their income regularly. And also as well, kind of startling, 92% of our tenants had to cut back, admitted to us that they had to cut back on electricity, and 84% stated they had to go without heating in the last 12 months, either all of the time, most of the time, and some of the time, which, you know, I've said it already, but when you consider having heat in Ireland in winter, it's a necessity rather than a luxury. However, despite this, 79% stated they always had enough money to cover their rent, which I think really shows that people are prioritising the most basic essentials, and then everything else is just deemed a sort of luxury or non-essential. Another thing in terms of mental health and well-being, so another thing for us was 45% of our participants either strongly agreed or agreed that they often felt lonely. And then, however, more reassuringly, over 90% of our tenants stated they knew where to go if they needed help with their mental health. So that's slightly more positive statistic, considering the third biggest chronic condition was mental health conditions. So slightly more positive in that regard. So I guess what are the key learnings from this study? I think the main finding for us is that the majority of our tenants want to age in place. Their homes aren't just bricks and mortar to them. It's a place of security and stability. It's a community, you know, and moving them out of their home or community should really be a last resort. You know, it's so much more than just a house to these people. Also as well, people with experiences of homelessness possess unique needs that other adults their age in the community may not have, particularly around chronic health conditions. So we know from our sample, they are much more likely to experience conditions which would primarily be seen in people who are 20 years older than they are, and they're much more likely to see them at a much earlier age. And so I think for this, we really need to start advocating for care supports that are needs-based rather than age-based. Also as well, despite the majority of our tenants being in receipt of some social supports, some form of social supports, tenants were still unable to have their basic needs met. And I think this really highlights that more needs to be done to advocate for improvements in disability allowance and state pensions, which many people have worked their whole lives to receive, and it's still not covering what they need to survive. Also as well, just additionally, I think one of the biggest things for us, tenants admitting that they went without heat or electricity really emphasised the real world consequences of the cost of living crisis. And also, despite them receiving fuel allowance, 84% of survey respondents reported going without heating in the last year, which again shows that the allowance is inefficient for what they need. And one of the problems that they had that was mentioned was poor insulation. And we know that poor insulation can exacerbate financial problems and also worsen health conditions. And I think this is a particular concern for those with respiratory conditions, which was one of the main chronic health conditions our respondents spoke about. And we know from the literature that older individuals already struggle with thermoregulation, meaning that they could be at higher risk of illness and disease. So that will only get worse as they age. So I think that also is a really good example of showing how housing and health needs are kind of inextricably linked, which kind of leads me on to my next point, that any solutions to these problems must be viewed as inherently tied together. They're not standalone issues. They need to be fit together. Also as well, just like to give you another example, it shows how health needs very often impact unrelated environmental needs. So again, as I said, our survey respondents identified accessibility and proximity to facilities as top priorities. But that's not really that surprising when you consider almost half of them experience mobility issues that cause them physical limitations. So just, to caveat that health and housing need to be viewed as inherently tied together rather than standalone issues. And just finally, I think our findings demonstrate the importance of ongoing continued support from services to support tenants, not just their physical health, but also their mental health and well-being as well. So we've seen from this survey how important Focus Island is to our tenants, and how reassuring it is that they know who they can go to help get support with their mental health. So I think that's everything from me. Just for those who would like to read the report, it is available online on the Focus Island website or the link on this slide. So just thanks everyone for that. I hope I was on time, and thank you. I'll stop sharing my screen now.
Thank you so much, Laurie. That's really interesting, and I would figure there will be many questions for you after Eileen's presentation. Thank you so much. And then Eileen, please go ahead, and after Eileen's presentation, it's time for the questions and comments and thoughts, but you can already share them in the chat box or in the Q&A box that you can find below the Tube deck. Eileen, off you go.
Yeah, thanks so much. I'm really glad to be here. Thanks a million for the invite. So I feel like I'm just going to be talking around a lot of the really good points that Laurie's already made. Like, Laurie has found out all this stuff on the ground in real life. So in a way, I'm probably just giving you a little bit of background to this. I'll just try and scroll through here. So I'm going to talk a little bit about aging inequity, and then specifically a little bit about dementia inequity. So hopefully that'll be some use to people. So what I've done here is I've showing you a picture of a tram journey through Dublin. So these are the stops on the tram from the south side to the north side of Dublin. And Irish population data now is beginning to look at levels of affluence or wealth and deprivation across different catchment areas in Dublin. And the little map on the side, you can maybe see these are actually the house prices, the average house prices along the line. So you can see here on the left, the blue areas are very affluent, well-off areas, and the red areas on the right are what we would call, I suppose, deprived or disadvantaged areas. And if you do that journey, what you find is that people are losing 5 years of life expectancy from one end of the tram journey to the other. And this is due to, I suppose, stuff you all know well about the social gradient in health, particularly in chronic disease. But what's more stark is what we call disease-free or disability-free life expectancy. So if you live on the south side of this line, you can expect to get to retirement, so 65 years of age, without much significant disease or disability limiting your life. But if you live at the last stop on the north side, you can only expect to get to about 50 years of age without significant impact on your health or your mobility or different things like that. And if we add homelessness into this, you can see the drop off here. So if I live in Kilmacud and have a cousin who's homeless, that male cousin will live 40 years fewer than me, and my female cousin will live 50 years fewer than me. And I think one of the things we try to get across to clinicians who are working with these groups of people is that, you know, we're coming, most of us, from a very privileged background, very lucky in the resources we have, and the person in front of us in the emergency department or the clinic is likely to live half the length of a life that we are. So I think it puts into perspective the responsibility we have to do anything we can to either add some time to that journey or to support people to have longer periods of disease-free life if we can. So this is data from Dublin around median age of death for people who are homeless. So, you know, it's pretty consistent as we've looked at it in different papers, but it's around 42. And for women, it's even younger. Women only live in homelessness to about an average age of 33. And the mortality gets worse the longer you are homeless. I'm sure you know all of this stuff. But Sir Michael Marmot, probably a lot of you have read all of his books and papers, but what was interesting was the difference in quality and length of life across a single city. One of the worst examples, I suppose, or the starkest examples, was in Glasgow, where if you live on a disadvantaged side of the city, you can live up to 28 years younger on average than people who live on the wealthy side of the city. And, you know, Laurie has already talked about some of the diseases we find in excess, like chronic disease, mobility problems, things like that. But the reason why a psychiatrist is so interested in this is that it's not just cardiovascular disease and diabetes and stroke and things like this. It's also these other excess causes of death, drug overdose, alcohol issues, suicide, accidents and violence. So it's more embedded in social circumstances than, you know, just heart health or diabetes health or whatever it is. And the other issue is that all these conditions have been connected quite closely with adverse events in early life. And again, I'm sure you know all this data, but anyone who has more than 4 significant adversities earlier in their life is more likely to have these difficult health outcomes later on. So when we say a social gradient, it's not just, again, people below a poverty line or an affluence line have bad health and people above it have good health. People at every step are doing better than the people at the step below. So it's important to know that it's not just about, oh, if we throw a load of money at the bottom of the ladder, we'll improve their health and everybody will be okay. What we found is that if money is spent in a general way on services, people at top are still better able to take advantage of those developments and policies than people at the bottom. So it still makes more difference and gives more advantage to people at the top of the social gradient than people at the bottom. And when we talk about, I suppose, the impact of the social gradients in mental illness, you know, and Laurie talked about how common mental illness is in this group, it does also take years off your life. Addiction takes about 20 years off your life, schizophrenia 15 years, depression, you know, severe recurrent depression 13 years, and personality disorders, who are often sort of the bad guy of mental health problems because they're seen as troublesome and, you know, debates about whether it's real mental illness or not. But, you know, any illness that takes 15 years off your life, in my opinion, needs addressing. And if that was cancer, if that was any other disease, there'd be a public outcry about an illness that would take 15 years off someone's life. So again, this is probably familiar to everyone here, but this is just some of the ways these outcomes happen. So we see people who have childhood adversity, they get into difficulty even as early as adolescence in terms of their health and their health behaviours. And the adult outcomes are then everything Laurie has described: chronic disease, addiction, you know, and difficulty manage their own health. So this is sort of the traditional flow path that we sort of kind of have accepted. So you have trauma in your life, you can develop poor mental health directly from that. Often people make poor health decisions then around substance use or looking after their health, and that tips them into chronic disease. But I think, you know, while that's a believable pathway and there's probably some truth to it, this is my problem with it. People start to get into a place of judgment then, like, well, you know, is this sort of your own fault because you are smoking and taking drugs and you don't take your blood pressure medications and you don't look after your diabetes, etc., and you choose not to go into accommodation when maybe you've been offered it, etc., etc. So we get into this model of trying to decide who deserves care and who doesn't deserve care. So I worry a little bit about just accepting that pathway at face value, and I sort of prefer this kind of model that I've sort of made up. But it's looking at the commonality between early life trauma, which we know is pro-inflammatory, chronic disease, which we know is largely caused by inflammation, and I include dementias and neurocognitive illness in that. Serious mental illness, which a lot of people don't realise also has a significant inflammatory component. So for example, schizophrenia, we can predict in teenage years, people who have early symptoms, we can predict who is going to go on and develop chronic lifelong psychosis based on inflammatory markers in their bloodstream. So inflammation is important there. But also the whole social exclusion bit has a connection with inflammation, because what we found is that people with chronic inflammatory systems are sort of tipped into these kind of what we call sick role behaviours that make it more easy for them to be socially excluded. So they tend to be more sensitive to negative evaluation, to rejection. They're more sensitive to being stigmatised or treated badly if they go into hospital, and they tend to avoid being proactive about their healthcare. So they get kind of socially withdrawn and fearful of seeking help. But the positive side of that is that they are also more sensitive to kindness and care when they get it. So good experiences of care, and particularly healthcare, have more impact on people with this background than people from an affluent background. So I think that gives me hope that small differences that we make can make a big difference to the people we look after. So just really quickly talking about dementia, this is American data looking at the increasing profile between over 10 years really, since 2007, 2017, the increasing profile of older people in housing. And the difficulty, I think, when they try to explore why this is happening, is the shift from home ownership really to rental in countries that aren't designed to support people to rent. So, I mean, people here can contradict me, but in continental Europe, my experience is that there's a lot more acceptance of being a lifelong renter, and communities and rental structures are set up to support that. But certainly Ireland was a country of ownership, and if you didn't own it, you had really no security, and that's still the case really today. And what's happening is, if you look at our data, probably on average 20% of our income is going on mortgages and rent, but that's across all wealth gradients. If you look at people at the bottom of the social gradient, over 40% and up to 60% of their money is being spent on rent. And what happens then is you add on these excessive energy bills that Laurie described, trying to heat a poorly insulated house, trying to manage electricity and all that kind of thing. And suddenly you're starting to choose between food and heat. So people that should, in a previous few generations, be living, I suppose, the relaxed life with a paid off mortgage on their state pension, now have been lifelong renters. And suddenly with the drop in income when they go to old age pension, they can't actually afford to compete in the rental market in Ireland anymore. So they're forced out into homelessness at this stage of their life. And these are Irish figures. And I suppose if you talk to, the local councils who tell us about what these figures mean, they would say, oh, look, the percentage of people over 65 in homelessness is the same as it always was. But in real terms, with the dramatic increase in numbers of people homeless in Ireland, that is a numerical increase 3 times of people in what we would call old age and homelessness. So as Laurie described, anyone over 45, because of their physical state in terms of chronic disease and their medical needs, they're presenting with the same type of needs as people over 65, over 70 in a housed population. So I would call anyone over 45 in homelessness old. So this is a significant increase in people with significant health needs now in homelessness. And what's more worrying is the increased proportion in Dublin, particularly, of people over 45 rough sleeping. So we know they have complex health needs and they're sleeping completely without shelter. So when we look at dementia specifically, I know it's a lot in this slide, but it's just to give you an idea of the types of risk factors that contribute to someone developing dementia. And the ones in blue are the ones that are in excess in homelessness. So almost every risk factor for dementia, people in homelessness have more of it than people who have houses. And the other ones there, sort of hypertension, hypercholesterolemia, renal disease, stroke, they don't occur excessively in people who are homeless, but they're not treated. So if you have hypertension and you live in a nice house in the South City, you'll probably be on medication that will manage that blood pressure, and your GP will see you every few months to make sure it's okay. But if you're in homelessness, the likelihood that someone is managing that for you or that you're taking medications for that is much less. So what you've got is things that really contribute to dementia that could be easily managed but are not managed because the person can't access healthcare. So this is sort of a mix of Irish and international data about how the prevalence of dementia looks in this group. So if you're a housed person in Ireland, the rates of dementia over 65 are about 80 per 1,000. And if you are homeless, it is 10 times that. So you have 10 times the risk of having a dementia if you're over 65 and homeless. But what's really scary is the proportion under 65. So, pre-senile dementias are relatively rare, 4 per 1,000 in a housed population. But if you analyse people between 30 and 65 in homelessness, the international data would tell us you can expect about 250 of them to have a meaningful cognitive impairment, so one that's sufficient to have an impact on their lives. So if you look at housed people in general, the average age for onset of a dementia is 84. But if you look at homeless people, the average age of onset for a dementia is 56. So that gives me about 10 good years left in terms of my function. I mean, that is a frightening thought, that if I was in homelessness now, I could expect to have a full dementia diagnosis within 10 years. And the reason it's even more, I suppose, challenging for this group is that there's a difference between young onset and late onset dementia. So the red line on top is how people's function is if they don't develop a dementia over their lifetime. The little orange line here is what we call late onset dementia. So people that get dementia in their late 70s or 80s. So what happens is they have a very small sort of drop off in the early years. And by the time they're at the end stage of disease, things are getting bad a little bit quicker. But if you look at this early onset group, we know because their systems are so highly inflamed that they go off a cliff very early in the course of dementia. So what happens is that over the first 1 to 2 years of the disease, they lose an awful lot of everyday function. So being able to look after their self-care, take their tablets, collect their money, launder their clothes, whatever it is. And if you can imagine the amount of cognitive reserve it takes to navigate the chaos of a homeless environment, it's double the impact then if you're homeless, because you're having to deal with places that don't have a steady routine, with a lifestyle that isn't predictable and the same every week. So the burden on people in homelessness trying to cope in setting of this cognitive drop-off it's hard to imagine actually for the rest of us. So when we think of people who are housed who have early onset dementia, it's a very, I can't speak to other countries, but certainly in Ireland, it's a very difficult situation. So often people aren't expecting someone in their 40s and 50s to have dementia. So the diagnosis can be slow and they can be misdiagnosed or not referred for assessment in good time. So even if you have your own house in Ireland, the majority of people find it very difficult, as Laurie said, to age in place if they have a young onset dementia, because we don't have the social care set up to come out and deliver care to people in their homes. So there's already an inequity, even if you're housed. There's almost no access to appropriate day services. So in terms of cognitive rehabilitation or therapeutic environments, even people who are housed can't access them because they're all set up for old people. People in their 40s don't want to go and spend their evening playing bingo. They have different interests. They have young children. They want to try and navigate this change in lifestyle and occupation. And the messages that we're giving old people who don't have those kind of dependents on them are very different to what younger onset people need. There's almost no respite care because it's all geared to people over 65. And the long-term care environment, again, like the day centres, it's not appropriate for people with young onset dementia. They have nothing in common with the activities and the people that are in those places. And it's really horrible the way they slip between services. Laurie said it really well, like this idea that you don't meet anyone's criteria because everything is age-based. So the younger health and psychiatry teams say, oh, we don't do dementia. And the older teams say, oh, we only do over 65. So people get no care. And it's really, really difficult. And that's if you're housed. If you're not housed, you can add on all these other problems. Because early onset dementia selectively tends to be not very forgetful dementia, like your classical Alzheimer's. It actually affects mood, social functioning, speech, and decision-making more than your traditional Alzheimer's picture. And with the group of people we look after who are socially excluded, often that's diminished or dismissed as intoxication. Oh, sure, he's drinking all day. Of course, he has slurred speech. Of course, he's clumsy and is falling, stuff like that. So everything they present with is attributed often to addiction problems or other social issues. And their behaviours can be interpreted as challenging behaviour. So what often happens is you've got people with a background of trauma who already have problems regulating their emotions. And if you add dementia into the mix, so they have problems with executive function and planning and decision making, all those behaviours are multiplied. And everyone who is used to them from the past saying, oh, that's just Jimmy, he's worse than ever, he's always fighting with everybody, etc. And they get excluded from accommodations. Rather than getting more support, they get kicked out. And they're more likely then, as Laurie said, to have untreated medical issues as well. Now, if you take a vulnerable brain that already has a cognitive problem or a dementia, and you add a medical illness on top of that, we all know the outcome of that is often delirium. So acute confusion, absolutely bizarre behaviour. People are disoriented, they don't know what's going on, they can't make decisions. And every single time that happens, it's another step down in terms of their brain's function, because that is an injury to the brain every time they get a delirium. So what happens is, instead of a slow decline in their cognitive function, they're jumping down, big step down, because they're getting all these intercurrent medical episodes as well because of their poor health. So then I suppose these are the things just to raise for the discussion piece is, how can we get people recognised and diagnosed in time? Because there are medications that can make a difference. They can slow the emergence of poor function. And, if people aren't getting seen because everything is getting attributed to bad behaviour or intoxication, we're doing them an injustice by having inequitable access to treatments. And then who's going to care for them? So already we've problems looking after people with young onset dementia, but what if you have an addiction and are homeless? What kind of organisation organisation is going to provide that kind of care. And if you take something like Housing First or Focus Ireland, there are challenges to that too, even if it was widely available. Because if you take someone with a cognitive drop-off, take them out of their familiar routine and environment and put them into a spanking beautiful new apartment, they will struggle because they've lost the routines, they've lost the familiar faces, they've lost all the environments that they're familiar with. And often what you'll see is an absolute crash in terms of function because you've taken them out of something they know and are used to, and with the best will in the world, you've put them into what you think is a different situation. The amount of support and adjustment that would require in someone with the dementia is absolutely huge. But in Ireland, I think the culture is, well, you know, the hostel is too crazy for them. We should put them in a nursing home where they'll be safe. But I'm sure lots of people know this here, but I would be so reluctant to take a 45-year-old and put them in a nursing home. The average life expectancy when you go into a nursing home is 1 year. So we're basically taking a young person and almost giving them a death sentence by saying, look, we're going to put you in here. Yes, you will be safe in that someone will give you food and help you dress and shower or whatever. But the emotional impact and the functional impact of being put into an institution cuts absolute years off these people's lives. So nursing homes are not the answer here either. Again, if you've no home, how do you get home care? You know, this aging at home is everyone's goal. But if people in houses can't get care, how are people in hostels going to get care? And the mortality we talked about, I'm very scared about the model of sending people too early to a nursing home just so they'll be safe. And then this bit about behavioural management. So if you have a primary experience of poor emotional regulation, a history of trauma, feeling unsafe in your life, having difficulty trusting people, and I give you a memory problem on top of that so that you don't know who this guy is coming into your room, who says he's here to give you a shower and you've never seen him before, can you imagine the fear response that would bring up in a person? So what you've got is all the pre-existing problems, plus someone has said, well, you know, you can come to this place, but we won't tolerate your addiction here. So you've taken away all your emotional crutches that you used before and then put you in an institution of strangers. Of course, there will be behavioural challenges. People will fight, they will kick out, they will shout. And this is why they tend to get excluded very quickly then from support organisations. So I don't have answers, and I'm sorry, I'm just bringing problems in a way, but I just want to emphasise exactly what Laurie said. What people say they want is what I want for people to be able to age at home. And if home means a long-term hostel where they know everybody and the staff love them, that's home too, and we should be able to get care into those sites as well. So that's it. Thanks very much for your time.
Thank you so much, Eileen. Really interesting stuff, and I am sure that there was plenty of new things for the people as well. At least for me, there was loads of new things as well, and I especially enjoyed the tram example. I think that's really nice one. But hey, we have almost 40 attendees here today, and the floor is yours. If you have questions, comments, thoughts, either on Laurie or Eileen, feel free to raise your hand or put them to chat box or Q&A box, and you can find those solutions below the Zoom deck. Like I said, you can also raise your hand and ask the question and put your camera on. There is Paul Rocks. Go ahead, Paul.
Hi everyone. Thanks for the presentation. This is really good from both of you. I just on the last point there about people with dementia and like obviously early onset dementia in housing them through the Housing First program. We've had that experience of that and moving them in, and definitely very, very intensive work can be done. I think having an occupational therapist is key to that. And the pre-tenancy work that's gone into that beforehand is like, you know, weeks of orientation and getting to use the keys and getting to know the neighborhood and beginning a new routine, you know, and then trying to maximize people's independence. But the people would obviously then will require daily, not twice daily visits after that, even really. Like, you know, so yeah, like that's my experience of it, where it's working well, you know what I mean, and doing that. But I don't know what's your experience of people being housed with early onset dementia, and have they had those additional support, that intensive support package to go with it?
I think the intensive support package does work, Paul, and it makes me so happy to hear you describing that, because that's exactly the way we'd like it to happen. And I think the advantage of the early onset dementias is that they tend to be less amnestic, so they've less forgetfulness, if you like, and it's more around organisation and decision making a lot of the time. So that gives us a chance to put in really practical supports that help them get used to routine. Even just things like reminders around the house, calendars, lists, you know, names on presses, whatever it is that can help. There's a lot of practical stuff you can put in if people's problem is more around organisation and decision making than around memory. But I suppose my experience is that we haven't had always access to that kind of support. And the question is, like, how long is it sustainable for? Like, if a person has limited cognitive capacity for learning new routines, you know, do you say, okay, we'll do it for 3 months, or we'll do it for 6 months, or we'll do it for a year, or we'll do it for 2 years? I think the difficult thing then is how and when do you pull it away? And, you know, how would you keep that up long term? I mean, it's fantastic what you're doing, but I just wonder how you manage those.
Yeah, I think in the long term, it's I suppose you're reviewing it daily, aren't you? I mean, like, you know, but I think the other thing with people with early onset dementia, we've put out in the community, there's a vulnerability as well to them, yeah. So that's it. So if they get known by, say, other people who might be don't have accommodation, they can struggle to manage the door, and that's like in the one case I'm really thinking of, that was ultimately why the person was taken out, because they couldn't manage the door. Then they came out, we got a diagnosis, and then they were in the shelter in the emergency for a long time. They've actually gone on to nursing home. Person was maybe was older, but maybe in the late 50s, you know. But yeah, we kind of just keep the support going is what we can do, which is it takes a toll on staff as well, for as long as maximize independence as long as we can while it's safe to do so. You know?
Yeah, but you gave that person whatever amount of months even before they went to nursing home. Like, that's a great gift to give somebody. But I think you're right about the OT piece. Like, for us, OTs are so imaginative at coming up with strategies. We had someone in that situation and they put in one of those Ring camera things at the door, and it would dial, like, they didn't have a huge amount of visitors, but it would dial or send the picture through to a key worker or support person in the family who could then help the person inside make the decision, do I open the door or do I not? So OTs are brilliant at coming up with some practical solutions like that. They're great.
Thank you, Paul and Eileen. And then we have Kalamai.
Thank you guys so much for the presentation. It was really helpful and educative at the same time. What I wanted to say was I learned a lot because I discovered we have a lot of community members that sometimes we think sometimes their problem is a shelter and their core problem is not a shelter. You offer them a shelter to stay and they turn them down, and they have more to deal with than a shelter. And we fail to understand their core problems and to help them solve the root cause of their problem. And we look at it just shallow, like it's a place to sleep, which is deeper than a place to sleep. Because I've seen so many cases like that, where you see somebody, you try to offer clothing, food, you reserve a shelter for them, link them resources, and they're not still ready to go in for. And it takes a long period of time. The same community members for about 5 years, 6 years, 7 years, and the person finally gets help after wasting a long period of time, just because we could not place our hands on the person's root problem. And when the successful day comes, they could just finally say, this person needs maybe to go for detox. This person had maybe problems from trauma from why they were growing up that still affecting them. You see their problems were really deep than what we were seeing. So I'm so happy for this because it's really it's important for us to understand that not everybody in our community only needs a place to sleep. We need to walk along with them, understand what is really disturbing them, and help them the right way. Because you give someone a shelter, you don't see any progress in their lives. Sometimes you see them coming there throughout their life. You get them a job, get them everything, but you still see them coming. They're not ready to work. They're not ready to do anything at that time. You feel you start being judgmental, not putting yourself in their shoes and understanding what they're passing through. So thank you guys so much for the presentation. I really enjoyed it. Thank you.
Thank you for the great comment and thanks for being here as well. Then we have a Q&A box. There is one question from Sophie Dorman. Would there be a preference for aging in community living or in individual housing? And I think this is for both of you. Laurie, if you can start.
Yeah, so I can only really speak to the findings from our report. But so obviously the largest answer was that people wanted to stay where they are. However, the next biggest answer was that they wanted to stay within the community, but maybe move to a place that was slightly more manageable. So for a lot of them, when we spoke to them, it was a case of, they're on the 3rd floor and they wanted to move to the 1st floor. And we're kind of fortunate that we have the ability to do that. We can transfer our tenants and stuff like that. But yeah, for ours, I think people don't realise how important community is for people, and how much, especially homeless communities, how much they establish links with people who maybe, so in our responses, access to friends and families, a lot of them were quite limited with that. And so they had developed sort of community links with people around them, you know, their neighbours, people who have kind of experienced the same things they have. I mean, that's very important to them. And it's a really big importance when it comes to aging in place, you know, and I think people often forget that. So I would just say, so in terms of community living, you know, like old age, we never really asked that question, but certainly we would recommend trying to keep them as close to the area that they're from as you can, because those kind of informal links are just so important when it comes to aging, you know, especially within homeless communities who maybe don't have the support networks that we very often take for granted, you know.
Thanks,
I don't know if
Eileen.
that answers.
No, I think it's a really good answer. Eileen, you want to add something?
Yeah, no, I think I'd agree with Laurie. I think you can underestimate the difference it makes to your life to have those connections. I think one of the issues with certainly the people I look after is that often they've lost a lot of family connections. So their family are the people that they've been in homelessness with, in their day centre, in their club, wherever they're going during the day. And to rip them out of that and put them into a community where they maybe feel judged or don't feel, you know, the same as everybody else is a huge stressor. But one of the models that I worked in that I liked the most was this idea of a sort of, it was like a gated community, and on the outside were independent units. So people had their own little apartments or shared houses if they were in couples. And what would happen is that they lived there with no sort of intrusion, but they could come into the center of this hub and use, for example, the dining hall, the social club, the laundry facilities if they wanted to. But there was also a bus going out through the day to the center of the town. So if they wanted to stay linked in with people outside the organization, they could. But the next step then was moving into slightly more supported units. So it was group living with carers going in, maybe helping them with medications, bringing the meals out to them if they didn't feel able to go into the dining area, helping them with keeping the house and laundry. And then finally at the very centre was something closer to a nursing home where they actually needed nursing care. And what it meant then was that their peers were the same peers for 10 years or 12 years or whatever. So they didn't feel as they were moving towards higher levels of care that they were leaving all their friends and connections behind. It was all the same faces, all the same staff, all the same environment. So there weren't any huge changes, but they could access higher levels of care as they needed. And I mean, for me, that was a lovely, gentle way of, you know, giving people the help they wanted, but not ripping them out of their community.
Thank you, Laurie and Eileen. And then Julia, I saw your hand was up, but do you have a question anymore, or was it the same question?
Hi guys, I'm not sure if you can hear me.
Yeah, we can hear you.
Oh, great. Okay, so thank you for the presentations. I'm Julia from Warsaw, Poland. I find them very inspiring. Actually, in my country, the death of people experiencing homelessness is considered mostly in the context of deaths from freezing during winter months. And those statistics fall down rapidly as we have more intense street work and mindfulness. I mean, the services concentrate on that place of death. However, we have hardly any statistics on how many people actually die in services of various kinds. So I find your data really inspiring and hope to be able to do something about it in my country. I wanted to ask you one question. What do you think? Do we need, because actually homeless population in Poland is really getting older, right? We have a group of people who have been homeless for many, many years and now are in their 60s. And some stakeholders feel the need of creating, special nursery homes for people with the experience of homelessness. The other idea would be opening access to people with experience of homelessness to general mainstream homes. What are your thoughts on both choices?
Eileen and then Laurie.
I was going to make Laurie go first. That's a hard question. I have sort of lots of thoughts on it. I mean, I worry that people get stuck in a ghetto of homeless care, and it's very hard to shed the identity of being homeless. So if we start creating little hubs of care for homeless people and, well, they'll all go there, I think what it does is it enhances the separation or the feeling of difference from mainstream care and mainstream communities. But I think what might actually be needed is more support, skilled support for mainstream organisations to be able to understand the needs of this group are different, and that they might need more consideration of trauma, more consideration of what it's like to have an addiction, more consideration of what it's like to have been damaged by institutions over your life. You know, a lot of people will enter a nursing home and their only previous experience of institutions will have been foster care, prison, involuntary psychiatric admissions. These are not warm, friendly experiences of care, and that might be the only experience they've had before. So I think rather than ghettoing people in homeless care, I think we need to upskill mainstream staff so that they have a better understanding of the needs. I mean, what would you think, Laurie?
No, I totally think, yeah, I'm so glad you took the question first, Eileen, as well. But no, I completely agree with you. That's exactly what I thought. Like, I would be very apprehensive to just almost round up this homeless population and just cast them outside the outskirts of town and keep them there, and then that's it. Because very often what happens is you just end up with them being forgotten about again.
Yeah.
And as you said as well, you know, early onset dementia doesn't just happen to people with homelessness. It happens to people who are housed as well. So rather than taking it as a purely homeless issue, it should be a case that it's needs-based rather than age-based that we're looking at with these diseases. And I definitely think, as you said, about staff, just general staff. I mean, we're quite fortunate. Obviously, homeless services are trained in trauma. We're trauma informed, but it's quite surprising how little. I mean, you've seen it, you know, care support staff very often are taken for granted and they're not viewed as real workers, real health workers. And so they're not given trauma-informed training. They don't know what to do in this. They just see someone who is acting out, is aggressive, and very naturally, well, you know, they don't want to do that. They don't want to add. But if they were trained in trauma, given that understanding, it would make it so much easier. And I think as well, when you build things for everyone, very often you find it helps everyone. Do you know, if you design things for the most vulnerable in our society, that has a knock-on effect, not just for the homeless population, but for so many other people, do you know? So I think that's a thing that needs to be considered. So rather than it being built purely for homeless people, I think it just needs to be viewed as a health concern for a vulnerable group, and, you know, have them included rather than excluded, you know? I think that's the best thing.
You've stolen my punchline, Laurie. No, I was going to say the same, that like a service that's accessible and caring and thoughtful for the people we look after is going to be accessible and caring and thoughtful for everybody. It will raise the standard for everybody.
Great, and I think stealing is good when it comes to good practices. So keep doing it. And then we are running out of time, but Kalamai, just really quickly, if you have one short question or comment, please go ahead, and then we will wrap it up.
Thank you so much. I just have a question again regarding the housing for aging population. Please, do you think, like, with the aging population, is it important to segment them? Like, for example, low barrier shelters and high barrier shelters, those using and those not using. Because at that age, it's strategic. Mixing them up with those that are like on drugs and they are still active users, and bringing them and allowing those that are not using to be in a common space with them. How do you see that for that age group?
Laurie and then Eileen.
Now, that is a very difficult question, and to be perfectly honest with you, I don't know if I would have the experience or sort of evidence to kind of answer it for you. I can understand why, but I mean, I think we need to first, that's a very high level concept question, and I think we're not even at that stage to even answer that. So I think maybe before we even answer that question, we need to look at the fact that services aren't addressing people with comorbidities, so people with addiction and mental health, and looking, like, very often people won't take someone because their addiction, a lot of mental health services won't take someone with addiction because of their addiction. And then very often addiction services won't take anyone without their mental health, with their mental health diagnosis. So I think we maybe need to address that first before we can start looking at, okay, if someone's using and not using. I think we need to try and address people. I think the service, certainly in Ireland, needs to start looking more at how do we address comorbidities first before we can then move on to sort of that stuff. My answer is I don't have an answer, and I wouldn't feel equipped to answer it. I think I think Eileen, you'd probably be more equipped to answer that question personally.
Yeah, it's a tricky one. Like, I mean, I worked for a long time in old age services before I came to this job, and we definitely, say for inpatient care or long-term care, we did separate over 65s from under 65s, partly because of physical frailty and the ability to handle the rough and tumble of wards where things can get aggressive, can get physical. And the other issue is, as you said, the cognitive vulnerability, like you described there. I think it was Paul talking about somebody who can't manage and wouldn't have the understanding to keep the door closed or understand who was a risk to them, whether it's a financial risk or a cuckoo, risk, someone taking over their property. So for that reason, I think there is an argument that the needs of this group are better looked after as a cohort, but not necessarily because they're homeless, but because based on their needs, as Laurie said. I mean, looking, what does this person need, and not deciding they're over 65, they're under 65, they have dementia, they don't have dementia, but doing a comprehensive assessment and saying, what is the best place and environment for this person, regardless of age or gender or addiction or whatever. And I think we need to get more tailored and do case-by-case reviews of that, rather than have a rule that says everyone over 65 without an addiction goes in this place, everyone who's 40 and takes crack goes in this place. And I think it has to be very person-centered and say, what does this guy need on this occasion, and we'll meet those needs now, and if they change, we'll move into something else where his needs will be met.
Thank you, and our time is up. I cannot thank you enough, Laurie and Eileen. It was really, really interesting, and I would say, my opinion, this made it visible that homelessness is a healthcare problem, that we need to do everything in our power so we can prevent homelessness happening in the first place, and if it's happened, it will be brief as possible. So thank you so much. And then if you want to know more about the upcoming Housing First Europe Hub webinars, feel free to go to the housingfirsteurope.eu. Next week, there's a really interesting webinar regarding the Denmark Housing First strategy, National Housing First strategy. So hopefully we'll see many people joining us there next week. But have a great day, and then greeting from the sunny Helsinki, and take care. Bye-bye.
Thank you. Thanks. Bye.
Thanks, Juha. Thanks, everyone.